Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual, and today we're discussing some more important rules in the clinical care tips category. Rule number 97. Monitor the patient, not the monitor. So this is something I came to learn in fellowship when I was starting to do a lot of sedations for painful procedures, mainly fracture reductions. And in fracture reductions, we almost always use ketamine. As I've said before, ketamine is the only drug I know of that is a sedative, amnestic, and analgesic. So it's great for painful procedures. And at the Children's Hospital of Pittsburgh, just like many other hospitals, sedation is a fairly big deal. You have to have a full monitor of the patient, a dedicated nurse, sometimes a dedicated respiratory therapist, etc. And in our hospital, obviously the patient was on a monitor, heart rate, blood pressure, pulse ox, etc. It was then that I realized that oftentimes I was very stuck looking at the monitor and forgot to look at the patient. And one of my attendings alerted me and said, Yaron, stop looking at a monitor, monitor the patient, not the monitor. So this rule comes into play when you sedate a child, and every once in a while the alarm starts to go off, indicating the patient is hypoxic. At this point, oftentimes my nurse and or my resident start to get a little panicked, maybe crank up the oxygen, make sure the nasal cannula is fitting, etc., etc. But the truth of the matter is when you look at the patient, he is not tachypnic, his heart rate is not going up, and there's really no indication that the clinical status has changed. This is when I tell the resident and the nurse, let's monitor the patient, not the monitor. Unfortunately, the pulse ox probes oftentimes break and are not necessarily very accurate, so given the child looks well, not cyanotic, not tachypnic, not tachycardic during the sedation, even though the pulse ox indicates hypoxia, let's pause for a second, look at the patient, realize that everything looks okay, and maybe just adjust the pulse ox or get a new probe and see what we get. So monitor the patient, not the monitor. If the patient looks well, perhaps this is a false alarm. Of course, as I said before, a good ER doctor is always ready. So when I do sedations, I always have soap, suction, oxygen, airway, and pharmacy, in other words, medications. So certainly, taking this seriously is very important and not dismissing the hypoxia. However, realizing that first thing we should do when the patient becomes hypoxic is look at the patient, not the monitor, look for signs of cyanosis, stridor, which ketamine can certainly cause when it does cause laryngospasms, and understand that the patient looks well, we have time, and perhaps this is a false alarm. So remember rule number 97, monitor the patient, not the monitor. Rule number 98, name the diagnosis/problem. So this is a rule I like teaching when I teach PALS, Pediatric Advanced Life Support, something that I enjoy doing since I don't get to see critical kids very often. It gives me an opportunity to teach and therefore learn and practice intensive care, just a little bit. So one of the things that I teach in PALS is how to run codes, pulseless electrical activity, cardiac arrest, etc. And I very often tell the students that once you resuscitate the child and you found the etiology, it's very important to name the etiology and declare it to the rest of the team. The reason is because oftentimes your team is composed of several people, each of which is very focused on his own task. And nobody really knows what's going on with the patient except for what they're doing. So the nurse who's getting an IV is very focused on the IV. The nurse who's documenting is very focused on every word that every person says and trying to document the best she can. The respiratory therapist may be very focused on the hypoxia and getting the oxygen ready, or maybe the intubation cart, etc. Everybody is very focused on their task. And oftentimes, if I run a code or teach how to run a code, I tell the student that if you identified the cause of this child's cardiac arrest or that specific tachycardia, it's very important to declare it to the team so everybody knows what are we treating, and now everybody's on the same page. Specifically when it gets to PALS, everybody now knows which algorithm we are using. So a good example will be the patient that comes in maybe looking pale, maybe even hypoxic and in distress. We put him or her on the monitor and we find the patient to have SVT, supraventricular tachycardia. At this point, I know exactly what to do. It basically involves following a PALS algorithm. But if my nurse is so focused on the IV and the respiratory therapist is so focused on getting the oxygen, nobody really knows what's going on until I say something like, okay, guys, I think we have a case of SVT. Let's do XYZ. Once I say that, I think now everybody's on the same page. All my nurses know exactly what to do with SVT. Respiratory therapists to practice PALS and take PALS and get certified in PALS know what to do with SVT. So it just puts everybody on the same page. Now everybody knows that the next step will be IV, adenosine, and second dose possibly, and maybe even synchronized cardioversion. But once I say what the etiology is, it brings everybody to the same place and everybody knows what to do. I personally feel that until I say that, since everybody is so focused on their own task, it's a little bit chaotic and everybody's just trying to do that one thing. But once you declare the etiology, declare the problem, everybody's on the same page. Another example is the patient who just comes in with febrile tachycardia ill appearing. Oftentimes, we worry about sepsis, and again, just declaring to the team, okay, guys, I think we have a case of sepsis. Once you say that word, everybody knows what to do. So now my nurses know that they have to give fluids, possibly a blood culture, maybe even pressors, but it puts everybody in the same page, and now everybody knows what to do, or basically what PALS algorithm we have to follow. So remember rule number 98. Name the diagnosis/problem. Declare it to the team so everybody knows exactly what to do and what PALS algorithm to follow. Rule number 99. Have the parents for every resuscitation. So this is a rule I learned in residency when I was present for my very first resuscitation, and I saw the pediatric emergency medicine fellow encouraging the parents to be by the bedside as we resuscitate the child. I remember that initially that seemed very odd. Parents are clearly in distress, crying, and I thought this can affect the team emotionally and possibly compromise their clinical judgment. However, at the end of the resuscitation, which by the way went very well, the fellow was explaining to me that he likes to have the parents for every resuscitation, for several reasons. Number one, you always want to make sure the parents see and know and understand that you are doing everything you can for the patient. Although this may not sound very important, I think it's important for the parents to see that we're doing everything we can for their child. Give them some hope and make sure they see and hopefully appreciate all the efforts we're doing in behalf of their child. The other reason is because sometimes, many times, the specific information you can get from the parents is very helpful. A good example is when you resuscitate the child and maybe things don't go well, when the parents are there telling you that the child takes steroids chronically, now you know maybe there's some kind of an adrenal crisis here and giving hydrocortisone may go a long way. So the parents often know the child's past medical history, the medication he or she take, and that can really help you doing the right thing for the patient. So having the patient for every resuscitation for that reason may go a long way. The parents know the child, they know the medication, they know what happened in the past, they know what can help, and having them at the bedside can really help you out doing the right thing for the patient. So have the parents for every resuscitation. Now this rule can also be simplified and not go all the way for resuscitations, but oftentimes, again, just having the parents is very helpful. A good example, again, is when I see a child with sickle cell disease who is in severe pain due to a pain crisis. Oftentimes, having the parents and asking them, Mom and Dad, what does usually work for your child? I can give Toradol, I can give morphine, I can give Dilaudid. What has he gotten in the past? Oftentimes, especially with kids with sickle cell who unfortunately come to the pediatric emergency department quite often, the parents will indicate the specific medication and possibly even the dose that brings most relief to their child. They have seen this before, they've been in the emergency department with their child before, so having the parents at the bedside can be very helpful in doing the right thing for your patient. So remember, have the parents for every resuscitation and have them by the bedside. They can really be very helpful. Make sure you build yourself up for success and make sure the parents know that you're doing everything for their child and use them as a resource. Oftentimes, parents know everything there is to know about their kids, and the information they provide can help you do the right thing for the patient. And And that is it for today, guys. Thank you very much for listening. I appreciate it. I hope you check out PEM Rules and submit any feedback if you have any. Let's review what we learned. Rule number 97. Monitor the patient, not the monitor. Look at the chest rise, look at the overall status of the patient, look at the respiratory rate, etc. And don't forget, if the monitor indicate hypoxia or abnormal vital sign, pause for a second, look at the patient, and make sure this is not just a false alarm. Rule number 98. Name the diagnosis and or problem. When you lead a resuscitation and you identify the etiology for the patient's condition, name it, declare it to your team so everybody is on the same page and everybody knows exactly what to do. Rule number 99. Have the parents for every resuscitation. Make sure parents are aware you're doing everything for their child and use them as a resource. Remember, some parents know their kids very well. They know exactly what medications they take, what has happened in the past, and what helps the child in the past, and that can help you do the right thing for a patient. So have the parents for every resuscitation and use them as a resource. And that is it for today, guys. Again, thank you very much for listening. I hope you like Lenny Kravitz. This is one of my favorite songs by him, I Belong to You, with a great bass line. Have a good day.